Panoramic radiographs serve as a valuable screening tool for assessing dental conditions, identifying potential pathologies, and detecting traumatic injuries like fractures. Just like how a detective needs to know a good neighborhood before spotting a suspicious character, dentists must know what normal looks like to identify the abnormal. Therefore, this video journeys through the normal anatomic landmarks seen in the OPG. Landmarks in an OPG are categorized into hard tissue shadows of the maxilla and mandible, air spaces, and soft tissue images. Let us begin with the hard tissue shadows of the maxilla. In this segment, we will discuss the anatomy, the radiological presentation, followed by the clinical significance.
The pterygomaxillary fissure is a space between the posterior surface of the maxilla and the anterior border of the pterygoid plates. It appears as an inverted teardrop-shaped radiolucency on a panoramic image. The posterior superior alveolar nerve and the terminal branches of the maxillary artery pass through this fissure. Next, we have the bony cavity called the orbit, which houses the eyeball and various nerves, vessels, and muscles that move it. 7 bones come together to form the orbit. These are the frontal bone, sphenoid, maxilla, palatine bone, zygomatic bone, lacrimal bone, and ethmoid bone. It is visible on an OPG as a round radiolucent compartment with radio-opaque borders, located superior to the maxillary sinus. Most radiographs show the radio-opaque inferior border of the orbit. In cases of blowout fractures, a fracture line in the lower border of the orbit may be visible on an OPG, though a CBCT scan would be ideal in such cases. Moving on, let us discuss the maxillary sinus. It is an air-filled cavity in the upper jawbone, with its floor being composed of dense cortical bone. The sinuses appear as paired radiolucencies located above the apices of maxillary premolars and molars, and the floor of the maxillary sinus is visible as a radio-opaque line at the inferior aspect of the sinus. The closer the tooth roots are to the sinus floor, the greater the chance of complications during dental procedures, such as implant placement and tooth extractions.
Pop quiz.
Between the maxillary sinuses lies a pear-shaped compartment of bone, known as the nasal cavity, divided into 2 halves by the nasal septum. On an OPG, it appears as a large radiolucent area above the maxillary incisors, with the nasal septum as a vertical radio-opaque partition.
Pop quiz.
Wait, there's more. But before we go further down the rabbit hole, subscribe to our channel. Another structure visible in the lateral wall of the nasal cavity is a shell-shaped, wafer-thin, bony projection called the inferior conchi. This cranial bone is visible on a radiograph as a diffuse radio-opaque shadow. Next, we have a sharp midline projection of the maxilla at the anterior and inferior portion of the nasal cavity. Can you guess what it is? That's right. The anterior nasal spine appears as a V-shaped radio-opaque area located at the intersection of the floor of the nasal cavity and the nasal septum. Can you identify this joint that aids in speaking, chewing, and yawning? Yes, it is the temporomandibular joint, formed by the condyle of the mandible and the glenoid fossa. The glenoid, or the mandibular fossa, is a concave depression in the temporal bone, where the mandibular condyle rests, It appears as a concave radio opacity positioned superior to the mandibular condyle on the radiograph. Anterior to the glenoid fossa is a bony projection called the articular eminence. On the radiograph, it appears as a radio-opaque projection of the temporal bone. Understanding the normal anatomy of the articular eminence and glenoid fossa is essential as it helps diagnose and treat TMJ disorders. Next, we have the zygomatic arch, the fusion of the temporal process of the zygomatic bone and the zygomatic process of the temporal bone forms it. On the radiograph, it appears as a radio-opaque structure located anterior to the glenoid fossa. Although zygomatic arch fractures are best viewed in submentovertex projections or a CBCT scan, in rare cases they may be visible in a panoramic view. Let us now discuss a slender pointed projection of bone known as the styloid process. It extends downwards from the inferior surface of the temporal bone. On the radiograph, it is a long radio-opaque spine, extending downwards and slightly forward from the temporal bone, anterior to the mastoid process. Normally, it is around 2 to 2.5 cm. An elongated styloid process of 3 to 3.5 cm and more may be a sign of Eagle's syndrome. Eagle's syndrome occurs when an elongated styloid process or calcified stylohyoid ligament causes recurrent throat pain or foreign body sensation, dysphagia, or facial pain. Additional symptoms may include neck or throat pain with radiation to the ipsilateral ear.
Pop quiz.
Moving on to the hard palate, the horizontal bone that separates the nasal cavity from the oral cavity. Radiographically, it appears as a radio-opaque band situated above the apices of the maxillary teeth. Cleft palate, a birth defect involving the palate, can be appreciated in an OPG. A prominent landmark on the OPG is the maxillary tuberosity, which is a rounded prominence of bone extending distal to the third molar. Blood vessels and nerves to the posterior teeth enter the maxilla from here. It appears as a radio-opaque bulge posterior to the third molar region. Clinically, a common complication of the third molar extractions is a tuberosity fracture. This concludes our discussion of normal maxillary hard tissue landmarks visible in a panoramic view. Moving ahead, let us discuss the landmarks of the mandible visible in the panoramic view. We mentioned earlier that the TMJ is formed by the glenoid fossa and the condyle of the mandible. The mandibular condyle is a rounded bone projection extending from the posterior superior border of the ramus of the mandible. On the panoramic radiograph, it appears as a radio-opaque projection that articulates with the glenoid fossa of the temporal bone. Condylar fractures and TMJ disorders can be assessed in an OPG. Next, we have another bone projection extending from the antero-superior border of the ramus of the mandible. This is the coronoid process, which radiographically appears as a triangular radio-opacity posterior to the maxillary tuberosity region. Between these two projections is a scooped-out concavity of bone called the mandibular notch. On the radiograph, it is visible as a radiolucent concavity located distal to the coronoid process on the superior border of the ramus. Now both halves of the mandible are divided into a body and the ramus. The body is the mandible's lower part holding the dentition. The ramus, on the other hand, constitutes the upper portion of the mandible and continues to form the coronoid process, coronoid notch, and the condyle superiorly. Fractures of the body and ramus of the mandible are visible on the OPG. Moving on to the mandibular or inferior alveolar canal. The inferior alveolar nerve and vessels run within this canal. The nerve provides sensory innervation to the lower teeth as well as to the chin and lower lip. It is a radiolucent band outlined by two thin radio-opaque lines representing the cortical walls of the canal. It is crucial to know the location of the inferior alveolar canal for dental procedures, such as tooth extractions, root canal treatment, and implant procedures. The possibility of damaging the inferior alveolar nerve is high during these procedures. Next, we have the inferior border of the mandible, which is a linear prominence of cortical bone. On the OPG, it appears as a dense radio-opaque band that outlines the lower border of the mandible. Along with this, the external oblique ridge is visible as a dense radio-opaque band that extends downwards and forwards from the anterior border of the ramus. Next, we have the region of the mandible where the body meets the ramus. This is the angle of the mandible which appears as a radio-opaque bony structure.
Pop quiz.
Moving to the mental foramen, it is a small ovoid or round radiolucency located in the apical region of the mandibular premolars. It serves as the exit point for the mental nerve and is an important landmark in dental procedures such as implant placement in the mandibular arch. Let us now discuss the air space images seen on a panoramic view. There are three air spaces: the palatoglossal, nasopharyngeal, and glossopharyngeal air space. The palatoglossal air space lies between the palate and the tongue. It appears as a horizontal radiolucent band above the apices of the maxillary teeth on a panoramic radiograph. If the tongue is not placed against the hard palate, this space becomes visible and leads to a loss of details in the upper anterior root region. Next is the nasopharyngeal air space, which is the portion of the pharynx located posterior to the nasal cavity. Radiographically, it appears as a radiolucent band across the coronoid process of the mandible. We now come to the glossopharyngeal air space, which is a portion of the pharynx located posterior to the tongue and oral cavity. On an OPG, it appears as a diagonal radiolucency located across the ramus of the mandible. Both the nasopharyngeal and the glossopharyngeal air spaces are often misinterpreted as mandibular fractures. Moving on to the final category of soft tissue images. The commonly seen soft tissue shadows on an OPG are the tongue, soft palate, and uvula, lip line, and ear. The tongue is a movable muscular structure attached to the floor of the mouth. On an OPG, it appears as a radio-opaque area superimposed over the maxillary posterior teeth. Next is the soft palate and uvula. These form a muscular curtain separating the oral cavity from the nasal cavity. Radiographically, they appear as a diagonal radio-opacity projecting posteriorly and inferiorly from the maxillary tuberosity region. Lip line appears in the anterior teeth region on the OPG. Areas of the teeth covered by the lips appear radio-opaque. We now come to the ear, which on the panoramic radiograph appears as a radio-opaque shadow, projecting anteriorly and inferiorly from the mastoid process. Sometimes it may superimpose the styloid process. Having covered several landmarks visible in an OPG, we hope this video has equipped you with a better understanding of interpreting panoramic radiographs. We have come to the end of this video.
Ever wondered how subjects can connect? Hit like and subscribe to watch our other videos.